Let's try it.
This is the fancy new setup that they have.
Wow.
Ergonomic desks.
It's magic. It's like Hogwarts area. Okay. Yeah. So anything else? Did I when I shut things down, the screens went up last time.
Perfect.
Okay. All right.
The system off and everything turns off. And then this is just log off.
Okay.
Yeah, I never asked if you needed a tutorial on how to shut things down.
Oh, shutting them down? I'm all there. It's getting into work again that I have my problem.
Oh, that's what I'm here for.
Yeah. Well, good. So I think.
That's what I'm thinking of right now.
Yeah.
Go stand in the back.
Yeah, that's right. Don't get too close to those. You're not going to use it. No.
You know, the kids let these hang down.
Yeah, no, I told my wife about your. Did you have something to do with the ground radar? What did you have to do with the presentation?
I did a lot of research about senators.
Oh, on sheet.
So I made notes, there's a few corrections.
Well, good evening, everyone. I'm Robert Hannon for University of Alaska Summer Sessions to this presentation on robotic surgery and technical advances in surgery. I'm told we won't ask for volunteers from the audience for tonight's lecture. Before I introduce our speaker tonight, I want to talk a little bit about what's going on. But even before that, I want to remind everybody with a cell phone, if you would silence them or turn them off, that'd be great. On Wednesday night, Kantishna Country is the topic by Tom Walker. He's the 2013 Alaska Historical Society Historian of the Year. And the topic is subcategorized Discovery, the History of a Place, Miners, Madmen, and Mountaineers. So that's tomorrow night in this venue at 7 o'clock. Thursday, it's down at the Jorgensen Botanical Garden, and the duo is Them Folkers. I'm pronouncing it as correctly as I can. It's a new spousal acoustic team playing bluegrass, folk, and blues covers. So that's down at the garden on Thursday at 7. And then on Monday, we have Using Unmanned Aerial Systems to Study Alaska's Environment. ISAA is an investigator at the Alaska Center for Unmanned Aircraft System Integration. So you can hear that interesting topic right here Monday at 7 o'clock. And talk about unmanned aircraft. I guess robotics is kind of, you want a surgeon behind there somewhere, I'm guessing. So let me introduce our speaker tonight. Dr. Kerry Wappett is a Fairbanks native, and he returned to practice in his hometown immediately after completing his residency training. Raised locally, Dr. Wappett left Alaska to attend Utah State University, where he graduated magna cum laude with a BS in biology. He spent 2 years in Portugal and Cape Verde in a missionary service with his church, and from there he traveled to Wisconsin, where he attended and graduated from the Medical College of Wisconsin in Milwaukee. After completing his medical degrees, he ventured on to Albuquerque, New Mexico to complete his residency in obstetrics and gynecology at the University of New Mexico. Professionally, Dr. Wappett specializes in minimal invasive surgeries, including robotic surgery, contraception and obstetric care. He has a significant interest in advanced laparoscopy and robotic surgery, as well as long-acting reversible contraception, high-risk obstetrics, and prevention in women's health care. I'm having trouble with some of these words. We could paraphrase them maybe. Anyway, he's a member of the American College of Obstetrics and Gynecology and the American Association of Gynecological Laparoscopists. He personally enjoys spending time with his family, fishing, playing guitar, skiing, and hobby farming. So please welcome Dr. Wappett.
Thank you. Hope that works. I appreciate you being here tonight. I know that the sunny days of summer, there have not been many of them, and you're inside where there's no windows. I would just start by asking, when you hear robotic surgery, well, the first thing I'll say is I want this to kind of be interactive. I have some things, but I want it to be interactive. So I'm going to just throw out there, when you hear robotic surgery, what are some of the things that you hear? What are some of the things that come to mind? Robots. There's a robot that's going to operate on me. Oh, no. Anything else?
The Terminator.
The Terminator. Terminator might operate on me. That's a problem.
Yeah.
So it's something that we hear a lot about. It's in the news. We hear positive things. There's negative things in the news. Just actually today there was an article in the Wall Street Journal about robotic surgery at Sloan Kettering in New York. So this is a topic that is interesting. This is a topic that is cutting edge. This is a topic that is surgery. So I will warn you, there are some pictures of surgery, and it's not too graphic. My goal was not to have a extremely graphic presentation. I'm going to leave time at the end for questions. If you have questions that pop up throughout, go ahead and ask them. So let's go ahead and jump right in. And let's talk about mining. I think I'm giving the talk from Wednesday, mining and mountaineering. Think about Fairbanks, and we think about the history of Fairbanks. It's a mining town. And we think about the people that came here. And they did the best they could with the technology they had. A pan, a shovel. Down under the ground. Working long hours. This here down on the lower left is a photo of a fire pit to melt the ground. This is actually out in Esther. Things moved along. They started to try and use whatever technology they had and be innovative, using water to power some of their mills, using pulleys to move the dirt, using gravity as with these sluice boxes here that you can see. Hydraulics. So we go from moving small amounts of earth, working hard, high intensity to get small yields, to let's use high-pressured water and move a lot of earth. A small advancement, but able to cover a lot more ground. Something that probably looks familiar to most of us. We'll find dredges throughout the interior. This is the robot of mining right here. Self-contained, could do it all. It was state-of-the-art at the time. But now you look at it, and it looks kind of outdated compared to where we're at now. This is Fort Knox, and this is a photo of the Fort Knox pit and the instrumentation and the technology that's applied in mining today. We think about the amount of earth they're moving, so they're moving larger amounts of earth. We're able to extract more ore and do it more efficiently. Now, we're going to take this and we're going to parallel it with surgery. So here's some early surgery. Sounds like a good idea. See this guy right here? He's looking at his friend saying, hey, why are we doing this together? So 650 Bc Trephination, they thought it was, you could put a hole in the skull, it would release pressure. This is an exhumed skull from early with this practice. And this was used and was thought to be great, cutting edge at the time. I don't think that that's a great idea. Greek battlefield surgeons. They did what they could. They took the sword out. They took the spear out. They tied it up. They didn't have much else to do. They didn't have antiseptics. They didn't have antibiotics. This is an illustration from Barber's journal illustrating all of the injuries that could happen during the Renaissance period. So you had to plan how to take care of all of these things. And luckily we don't have to do that. All of the instruments from a Renaissance barber was what they would have been called at that time. Looks more like wood shop over there than it looks like surgery. And it probably was a lot more like wood shop. Civil War. So the Civil War brought a lot of things. Civil War brought a little more efficiency to medical care. This is where ambulances actually, the ambulance corps in the United States was initially organized during the Civil War. And this photo is a group of 3 battlefield surgeons. And I keep trying to ask my wife if I can grow big sideburns like that guy, but she said no one would come and see me if I did. They did the best that they could with what they had. This is what they had. Amputation saw. This is their scalpel. A needle, reusable. This is, and you can come up and take a look at this. This is a kit, a battlefield surgeon's kit from the Civil War. This is a picture of them doing amputations, and that was their principal job during the Civil War. Had injuries to the extremities, they couldn't save it, it would get infected, they'd cut it off. So, anesthesia and antiseptic. This picture here on the left is at Johns Hopkins. This is one of the first demonstrations of ether anesthesia. The first time that you could put someone under, operate, and them not necessarily feel it. Here on the right is an early case in Maryland, just showing some as antiseptic technique as possible during a procedure. You can see, though, this is a major change from these fine young men standing on a table outside. We jump from anesthesia and antiseptic to the modern operating room today. If you walked into the operating room, all of them are slightly different, but the idea is similar. Everything's automated. You got lights off of the ceiling. You've got screens. You've got the anesthesia machine. Everything is extremely sterile. Everything is, we use aseptic technique. And that is a big jump from here. Miners wanted to move more land, wanted to process more ore. In surgery, the idea is to move less. We don't want to make big incisions. Now, this is what we would do hysterectomies through. What we do hysterectomies through traditionally, either an up and down incision or across. It's called a fan and steel incision. And this is the principal route of a hysterectomy, which I should also make a disclaimer that a lot of this information is in regards to gynecology, since that's what I do, and hysterectomy is one of the principal surgeries. I do have some references to the general surgical portion of this as well. This is a good procedure, and it's still done today, but recovery time is long. If you have a big incision, usually 12 centimeters, or even bigger in this vertical incision, recovery can take quite some time. And this is what you come home with. It goes away. This is just post-op and with sutures. But you do have a scar. You do have pain. You do have limitations in lifting. You do have nausea. You have vomiting. So we're going to jump to the next technological advancement, and that's laparoscopic surgery. This is a picture of a laparoscope, and it looks really, really old. In fact, it's not that old. 1985 is, this was one of the original laparoscopes, what it looked like when the first laparoscopic cholecystectomy or gallbladder resection was performed. It was done through something similar to this. Even earlier than that, the idea of placing a small incision and then putting a little camera in a cavity, in the abdominal cavity, in the chest cavity, was around. And people would make these little incisions, put these little cameras, and they would have to look directly through. They didn't have any optics. They didn't have video. They were just able to create a window and look through. It was merely diagnostic. They could look and say, yep, there's a problem there. And then, if there was a problem, they would make a larger incision. Laparoscopic surgery advanced quickly, and today we do a lot of laparoscopy. This just identifies as an image of the basic setup where we put a camera through the belly button, fill the abdomen with gas so that it's distended. We have several other incisions based on the surgery where we put small instruments that are similar in size to this through those ports, and we perform the surgery. This is what the operating room would look like as it's set up. You can see these surgeons aren't looking at the patient, but they're looking up at the screen. So up on the screen is the actual operative field. So we're what, 2014. In 1985, this gentleman, Eric Muir, did the first laparoscopic chole, which is a removal of the gallbladder. And at the time, there was all of this backlash. I said, this is crazy. This isn't safe. You can't do this. And it wasn't universally accepted. Today, if you have your gallbladder out any other way than laparoscopically, you are the exception. 95% of your gallbladders are taken out laparoscopically. In 2000, the first Davinci prostatectomy was performed. Once again, question was the outcome clinically significant? Is it worth pursuing this? Today, 85% of prostatectomies are performed with Davinci assistance. So the question is, where are we with robotic surgery today, and where are we going? And will this history of this is crazy, this is never going to work, repeat itself into now these are standard procedures? The robot is precise and pretty spectacular tool to do origami. That's why we have it, right? To do origami. As you watch this, these are actual robotic instruments that can be used in surgery. Just happens to be used here by a professor in Japan to illustrate the dexterity that you have when you operate with a robot. This is not a robot making this. This is an actual surgeon who's controlling these hands to fold this bird. Now that's pretty impressive if you ask me. What's more impressive, I think, is that it looks so wonderful and it's so small. Smaller than the size of a penny. He made it look easy. So if we compare the incision either up and down or side to side for a hysterectomy to what someone who has a robotic hysterectomy has, this is the difference. They will have 4 or 5 incisions, none of them bigger than 8 millimeters for the most part. And you can put them in numerous different arrays, but they're all very small. This is what they come home with. The picture on the left is probably about a week post-op. That picture on the right, you can hardly even see the incisions. If there wasn't an arrow pointing there, you wouldn't even know that this person had had surgery, per se. But cosmesis is not the only reason that robotic surgery is where it is and why it is so clinically important. Robotic surgery decreases the amount of open, traditional surgical cases. Yes?
There's a microphone on the thing that's what's causing the feedback. The
Farther away I am?
over this way, can you move the keyboard?
Sure,
a little bit?
I can do that. There we go. All right. So, with robotic surgery, we have decreased blood loss intraoperatively. We have decreased pain postoperatively. That only makes sense. 12 centimeter incision versus 8 millimeter incision. We have shorter hospital stays. So, the standard for a hysterectomy that was done with an open incision would stay in the hospital 3 or 4 days. Our standard is going home the same day of the surgery or the next morning. And ultimately, there's a more rapid return to day-to-day activities and normal day-to-day productivity. So if we look at the overall cost to society, we're returning patients back to their normal activities much faster. I tried to keep the numbers to a minimum. This is the boring stuff, so we'll go right through it really quickly. So if we look at this group, it says overall TAA, so an abdominal hysterectomy. Before the robot, 20% of hysterectomies were done in abdominal fashion. With the Davinci cases, 100 of them, 4% of them were converted over to an abdominal hysterectomy. And after that first 100, the next 25, there was no conversion to abdominal hysterectomy. So once again, just kind of confirms that. As you look, the uterine size for the robot doing laparoscopic surgery, 359 grams was the average size of the uterus we could take out. Whereas when you look at the robot, you can take out a 1,300 gram uterus. With laparoscopic surgery, 8% of the time, you couldn't do the surgery because of adhesions or scar tissue from prior surgeries. With the Davinci, in this case, or in this series, 0% conversion because of adhesions. They were able to complete all of their cases. And this identifies a shorter operative time than laparoscopic surgery, so 78.7 minutes versus the 92.4. Now, you look back at the first 100 and it's a little bit longer. There's a learning curve. Just like any new technology, there's a learning curve. So that's it. That's the robot. That's what you fear right there. The robot has several components to it. So on the left, you'll see this is the surgeon's console. This is where the surgeon will sit, has his face in this console, is able to see inside the patient through those glasses, which you will have better pictures of, and then controls the robot with his hands and feet. The patient cart in the middle there, so that blue drape is simulating where a patient would be laying. And that's the small little incisions on the abdomen and instruments through those incisions with robotic arms attached to those instruments. Nothing on that patient cart moves unless the surgeon moves it. It does not move independently. The surgeon controls all of the motions of those instruments, and I've got a bunch of these instruments up here that you can come up and look at after. So nothing moves unless the surgeon moves it. Then there's an instrumentation cart on the far side, screens for the assistants to see. You can have microphones to communicate between assistant and surgeon. It's got the power for cautery. It's got the video. It's got all of the instrumentation necessary to support the robotic surgery. If you were to walk into a room doing traditional robotic surgery, this is what it would look like. You can see the surgeon's not right at the bedside. So standard, surgeon scrubbed in, standing with hands on the patient. Here the surgeon is 10 feet away, but controls everything on the patient. Now there is an assistant that's always scrubbed in to assist with any changes of instrumentation or any difficulties with the robotic arms. But this is the standard setup. A little closer view of the patient cart. You can see right here the numbered arms 1, 2, and 3. So there are 3 arms that can have 3 different instruments. And then there's one other port that the camera goes through. And with that camera, you're able to visualize all of your instrumentation in the abdominal cavity. We'll see if all of these work. They should. So, I don't have any audio for any of this just because it doesn't have anything. But This is the assistant that's standing up by the surgeon. You can see as the assistant is helping with whatever he's doing, you can see the robotic arms moving. Those are being moved by a surgeon in a console. In this case, the assistant then grabs the camera and moves it by overriding the surgeon. So, why robotic surgery over laparoscopic surgery? And ultimately, it comes down to these three things. There's intuitive motion, there's 3D vision, high definition, and there's wristed instrumentation. So, with wristed instrumentation, you can move these robotic hands, these arms, in any of the direction that the general or your hand can move. And when you come up and you can play with all of these, you can see you can move them in all directions and have the same motion that your hand has. These are small, so 8 millimeters to 12 millimeters in size. These are just a combination of some of the instruments you can use. And this is what the surgeon's fingers are actually in as the surgery happens. So I'll show you some other pictures, but as that surgeon sat in the console and then has their hands in front of them, this is what their hands are in. So as they move their hand in their standard motion, it translates to the motion of the instruments within the abdominal cavity. On the left, this is a robotic instrument. On the right is a standard laparoscopic instrument, meaning no wrist, controlled directly by your hand. So we'll see the difference here. You can see you can only go up and down and open and close that laparoscopic instrument versus that endo wrist and the Davinci can go in all degrees, and this is all controlled. If you watch, the surgeon's hand is merely moving exactly like that instrument is moving, just like this, and then opening fingers, and it opens the instrumentation. It's steadier. It eliminates tremor. Sorry, this is one of the gory ones. It's not that gory, but it is someone's insides. One of the challenging things about laparoscopic surgery is tying knots. Try tying a knot with your hands like this and not bending your hands. It's hard, and that's what you get with laparoscopic surgery. It can be done, and people are very good at it. It takes time, it takes a lot of practice, and it's not as precise. So if you look at this, just watching the instrumentation, you can see how that wrist makes such a difference in being able to just grab these small sutures, tie this down. It's pretty amazing. Intuitive motion, what does that mean? So, instrument is inside the body at the top. The bottom is what the surgeon's hand is in to control those instruments. That is, all of this instrumentation that the surgeon's hand is in moves up and down, back and forth, twisting, and I've got a short video to show you. And this just kind of gives you an economy of scale. So if that surgeon moves his hand or her hand 6 centimeters, the instrumentation inside the abdominal cavity moves a mere 2 centimeters. Precise. I apologize about this. The end of this got cut off, but this is just a demonstration of throwing suture, and this is an extremely small suture that is used for vascular reanastomosis. But you can see as the surgeon moves their hand, it controls this again, and the end of it cut off. So I'll play this again. You can see the small motions of the surgeon's hand translate to passing the suture through, successfully closing that defect. It's nothing big, it's small movements. It's precise. Here's another gory one, sorry. 3D vision, so traditional laparoscopy. 2D, you can only see 2D. And when you put your head in the surgeon's console, you see 3D. You have depth perception. You have clarity. And I suppose that's a pretty good picture up there. This is a kidney. And we're going to see this picture again, just as a good demonstration of the clarity of this. So we can use the robot to take out gallbladders or uteruses or fold origami or peel grapes. And this, so this is the actual visualization that the surgeon would see. You can see the clarity. And the main thing that I wanted to show with this is as he starts or she starts to peel the grape, you're seeing a single layer, and how clearly you can see this single layer with this visualization. It's pretty impressive. Once again, the surgeon sits over on the side, controls the hands, and watch this, can just grab it and peel back. A single layer. That's going to be a tasty grape. Takes a little bit longer, huh? In addition to having 3D and HD, one of the new things that the newer technologies that Davinci has developed is called Firefly. So Firefly can use it in general surgery, you can use it in gynecology, and the idea of it is that you can give a small amount of dye, this ICG dye, goes into the bloodstream, it binds to albumin protein in the blood supply, and then from the camera that the surgeon is looking through, sends out an excitatory laser light, and then any of this ICG that is present where they're looking sends back a signal. So this helps in finding critical vessels, helps in finding any tissue that's viable or not viable, what needs to be taken out, what can stay. So there's a whole bunch of different applications that you can use this in. Here's our friendly kidney. So when you look at that, that all looks about the same. You can tell there's a little something in them all, but you can't tell a whole lot. When you turn on Firefly, so you can see where that green perfusion is healthy tissue. Where it's dark with no perfusion, that needs to come out. Another gory thing, sorry, this is just a... So this is looking at a colon. And so if you look at it when it's not this black and white, it'll flip back to the standard view. I think, if I remember right. That all looks the same. When he flips back, you can see the green, which is healthy, perfused tissue. And you can see a very definitive line right there in the middle portion where, to the right of that, there's no perfusion. And that will direct exactly which part of the bowel needs to be resected. Like I said, you can use this for bowel resections, you can use it for gallbladders, you can use it to identify endometriosis in gynecology patients. There's all kinds of applications. It's pretty impressive. So, intuitive motion, 3D, HD vision, and endo-wristed instrumentation. Those are huge advances in our ability to perform accurate and precise surgery. Now, how do you become a surgeon, a Davinci surgeon? First, you got to have an adequate volume. Sorry, I'm kind of changing gears here a little bit. So, you've got to have enough cases to keep up your skills. Anyone who, if you're a painter or whatever the case may be, if you don't use those skills, you lose them. So, have to have adequate volume. You've got to have appropriate training. So, you've got to have gone through the appropriate residency in general surgery, ENT, OBGYN, and have those credentials to operate in the first place. You then can go through a group of online modules and hands-on practice, and I have a couple of examples here. Then Davinci will actually take you down and have an 8-hour training session on pigs and cadavers. You don't want to do your first run on a patient. You want to do this safely, right? You want to know the instrumentation. You then go through a credentialing process through your hospital. You have to be approved to have proven that you've done all of this training. And then those first 3 cases, you're proctored. So there are physicians that have done hundreds and hundreds and hundreds of these that are approved through Davinci to be proctors. They will come to your 3 cases. They will watch you from start to finish. They will give you feedback, how you can improve, how you can be more efficient, if you're dangerous, what you need to do to change that. And then you use it. So, once again, if you don't use the skill, you lose it. There are advanced courses, so Davinci is always encouraging their surgeons to improve themselves. And just like anything in the world, if you buy a computer today, next month it's out of date. If you've trained a year ago, if you haven't done anything to hone your skills and to improve them and do advanced training, in a year, you're out of date. So they've got advanced courses that you can go to. If you feel like your caseload isn't enough, you can do training modules. So on the actual robotic surgeon cart, there is a trainer that, as you can see, is not a real patient. It's an animation. This is a surgeon that's going through each of these specific drills. The drills are meant to simulate skills that you'll use in surgery. So using cautery to burn blood vessels, cutting appropriately, being able to drive needles in a controlled manner and through targets. It's like video games for adults. I never got to play video games as a kid, so I got to do it now. How to control the camera. You can see that you've got to move the camera up to where other parts of the exercise are, and all of this is done just with your hands and your feet. So if you don't have enough caseloads, or a high enough caseload, and you want to keep your skills up, you can always use these training modules. So if we look at Davinci and intuitive surgery, this is a company that was formed in 1995. The robot was approved by the FDA in 2000. And if we look at all of the caseload, we look back in 2008, just over 100,000 cases. In 2013, there were 523,000 cases performed worldwide. This divides up urology, gynecology, general surgery, and others. So you can see that urology and gynecology are the principal users at this point, but there are more and more general surgeons, cardiac surgeries that are starting to use this, ENTs that are looking at this. So this is expanding. 16% increase in cases from 2012 to 2013 using Davinci. They're all over the world. So clearly the most in here in the United States, 216,000, but over 3,000 robots throughout the world. That's a lot of robots. In the U.S., this is based on the year and when the installation occurred. We're not on there. The Anchorage is. Fairbanks isn't, because we got ours in 2013. So there should be a dot right there in the middle of Fairbanks. This is just some visual of prostatectomy. So in 2001, 98% of them done open with a big incision on the stomach. 2012, 86% of them done robotically. Hysterectomy, open. 64% were done in an open surgery in 2005. 37% in 2012. Now you can see laparoscopic numbers have stayed about the same. Vaginal hysterectomy numbers are a little bit lower, but pretty close to the same. This is a great slide. It shows the abdominal hysterectomy on the top, this gray line, and the green line at the end being the robotic hysterectomy. Now you can see this purple line that's slowly creeping up is traditional laparoscopic hysterectomies. So you can see those numbers creeped up, but the abdominal hysterectomy rate really stayed the same until you see this introduction of the robotic surgery, and you see a significant drop. And to me, that's the key. Now, there's still a role for laparoscopic hysterectomy. There's still a role for some abdominal hysterectomies. But the fact that we can do the majority of these without making a big incision, that is a leap forward. Same thing, just a different slide. So if you look at literature, you're going to find literature that will tell you one thing, and you're going to find literature that will tell you another thing. And it's always changing. I will tell you that this is a pretty robust group of studies that looked at an open hysterectomy versus a robotic hysterectomy. Less blood loss, fewer complications, shorter length of stay, stuff that we talked about before. Quicker recovery, quicker return to productivity. Versus the laparoscopic hysterectomy, fewer conversions, so like what we saw in that earlier study, less prolonged length of stay, fewer readmissions, similar complication rates. So looking at those two compared, sometimes you'll find different things. Now, Brigham and Women's in Boston, that's a pretty big hospital. It's a pretty prestigious hospital. If you look at this, conversion rate of a Davinci hysterectomy, 0%, laparoscopic 4%, vaginal 1.5%. Post-op complications, 1.6%, compared to the next best, 3.4%. That's significant. This looks at Davinci versus a laparoscopic hysterectomy. Oh man, that doesn't help. The main things I point out with this is the third line. The robotic hysterectomy had a shorter length of stay in the hospital. Decreased cost. The robotic hysterectomy, the next line down, had a smaller number of conversions. Decreased loss of productivity. And the last, there was a lower rate of complications in the robotic hysterectomies versus the laparoscopic hysterectomies. Now, looking at operative times, blood loss, in this meta-analysis, they were consistent between the two of them. There was no significant difference. The cost. So this is where a lot of people have this question. Robotics isn't cheap, so a robot is around $2 million. And then there is upkeep and maintenance, instrumentation. So right up front, it's about $2 million. This is a great study from 2011 looking at not only the cost of the surgery and the instruments used during the surgery, but looking at hospital length of stay, anesthesia times, and all of that. And in 2009, just in 3 years, looking at 2006 to 2009, 11,000. Actually, in this study, it was the least expensive. Once again, you can find data that shows otherwise. So if you're looking at the cost to society, lowest for robotic hysterectomy. Now, Davinci and intuitive surgery is, they're always looking for ways to improve. So the Davinci S was the original surgical platform. In 2009, the SI was released, and that's the robot that we have at Fairbanks Memorial Hospital. 2010, they created the skills simulator to help surgeons remain up to date on their skills. 2011, the Firefly. 2012, single site. So one of the things that we're looking at, and actually is happening at Fairbanks Memorial Hospital, is single site cholecystectomy. So instead of having 3 or 4 incisions, they do it through a small incision, single site. Put all those instruments through that one site. We can do hysterectomies that way. And then advanced instrumentation. So new things, so new cautery devices, new stapling devices are being developed all the time. This is a pig, just so everyone knows. I show this because I think it's really cool. It's a pretty amazing. The picture is clear, but this device on the right is it's a sealer. So it uses energy to seal an artery that this hand on the left is holding, 7 millimeters. Look at the pulse pressure on that as it's pulsing. That they can use it, and they'll show it here again. They'll cut it again using this device, the vessel sealer, and it will hold against that pulse pressure. Doesn't leave anything there. Doesn't put any staples. Doesn't put sutures. Just look at that thing pulse. That'll keep you up at night. So that's in a pig cadaver. So I mentioned single site. This is illustration of standard robotic hysterectomy on the left and what a single site hysterectomy post-operative would look like. We go right through the belly button. You can see instead of the incisions being across the abdomen, it's through one single port. So, because this is a hot topic, because there are advocates and there are foes against the robot, there is a lot of research going on. A lot. So if you look at it, there's just these numbers here. 1,000 comparative studies. And that's averages about 100 per month. Like I mentioned, you had this one that was in the Wall Street Journal just today, or maybe it was yesterday, I can't remember. So this is being looked at, this is being studied, this is under scrutiny, but this is amazing. And personally, the results that I see from my patients who have robotic surgery versus an open surgery is just an amazing difference. When I can have someone come back and see me in a week after having an organ from their body removed, and they say, I want to go back to work. I say, what? I want to go back to work. Okay, if you feel good. So in closing, I want to leave some time for some questions. And I'll just leave this running. This is kind of the picture is kind of jumpy. It's not normally this jumpy. It's just because of the size of the file. Just showing the precision that you can have with the robot, suturing, using the dexterity, the wrist into instruments, closing a surgical site here. And this runs for a while. So as that runs, as you can watch that, I would be happy to answer any questions. Questions?
Are there different heads for the different tools, depending on if you're cauterizing or applying clip?
do they have to remove them from the body every time that they're going to apply a new head, or is there like one for each different head?
Yeah, that's a great question. So there's different heads, and depending on the surgery, you'll use different instruments. And so for a hysterectomy, you will put in 2 instruments, do the majority of the hysterectomy, and then when it's time to suture, you'll take out these instruments, and I have them up here, and you feel free to come up and look at them. You'll take the instruments out of the port and put the new instruments through. The idea is you want to limit the number of times that you have to do that, and so when you have 3 arms in, for the most part, you can do most of your surgery with 1 or 2 instrument changes, and that's all.
How many people do we have at Memorial Hospital that can do this now?
So I think the last number was 9 or 10? It's 10, yeah, 10. Yeah. So
How many people are in the operating room when it's actually done?
So generally in the operating room, you'll have your anesthesiologist, the surgeon, and the assistant for the surgeon, and then there's a scrub tech that provides all of the instrumentation for the surgical team, and then a nurse. There's sometimes one more nurse to help just with all of the instrumentation, so about 5 or 6.
2 questions. One, if I can see a small hole and you go down and remove something, you got to remove it. I can think of something big. And how do you have to slice it up to pull the pieces out, or how do you get it out?
That's a great question.
The second question is you have to sterilize something. Do you sterilize everything, or some of the parts of the real sensitive parts get discarded after one use?
Yeah, so the arm
Yeah.
that attaches to the patient has a drape that we put over, a plastic drape that's sterile. These instruments are all sterilized, and these are reusable for 10 times, and after 10 uses, then these are discarded.
The whole thing?
Just this instrument, yeah. As far as how do you get it out, that is a great question. So for hysterectomies, you can take out uteruses that are huge, and the majority of the time we'll actually take them out through the vagina, and then sew the vagina closed. Sometimes we have to do what's called morcellation, and we chop it up and bring it out through, for lack of a better term, that sounds terrible, chop it up. Sorry.
Section it.
We section it, and then remove it through the ports through a morcellating device.
Thank you.
So is it common to use a combination of this and vaginal?
So there is a laparoscopic assisted vaginal hysterectomy. We don't generally do that with the robotic surgery. Generally what we'll do is the entire hysterectomy robotically, and then just remove the uterus through the vagina. And then, actually this is closing the top of the vagina, so this is suturing it. It's considered a total laparoscopic hysterectomy with robotic assistance.
All of this so far is talking about going through soft tissue. Is there brain surgery that's being done this way as well, going through the skull?
There's not right now. There's some ENTs that are looking at transoral things, but there's not that I'm aware of.
The features of the fragments that are in inside. Does the surgeon get feedback on the pressure regime?
That is a great question. There's no haptic feedback. And so that's one of the skills that you have to develop, is that you learn to feel tension with your eyes. And that sounds like a silly thing, but once you have worked with tissue and you know how much pressure it can hold, you can feel that with your eyes. The arms have tremendous strength, and so you can have complications and you can damage things if you're not aware and very cautious with the strength of the robot.
Well,
looking at the next iteration, is artificial intelligence likely to be introduced at any point to analyze procedure while it's taking place to suggest or modify?
Not that I'm aware of. The Vinci and Intuitive understand that surgery is a very human thing, and there's not a drive to replace the human component of surgery.
Would it be feasible for the surgeon not to actually be present in the operating room and maybe operate remotely?
Yeah, it would be feasible. It could happen. Once again, I don't think Intuitive is going that direction. There is also a personal side of surgery, and there's something to be said to have a relationship with the surgeon. Even though the surgeon is using this robotic tool with an instrument, it's still the surgeon performing that surgery. So I wouldn't want someone I didn't know across the country doing my surgery. But yes, feasibly you could. Thank you. So the total number, the last count, so the first surgery was done September 4th last year. And between all of the surgeons, we've done approximately 110, 120? Oh, I've done 19 here. Then I did 63 in UNM, at UNM before.
I noticed the surgeon was sitting down and he had his feet somewhere. Did his feet do something?
His feet do.
His or her feet?
His or her feet. So on the floor are pedals that control the electricity, the cautery, control your camera movement, and it clutches, so it allows you to move your hands without moving instruments in the body. So you're using both hands and both feet.
Based on the information you've given us, why is it that most insurance companies don't pay?
Yeah, that's a great question. Because there's conflicting data, there are some insurance companies that still see this as experimental. Will there be a time that they will all cover it? I can't look into the future. I would anticipate that, yes, they will, when we have more and more data that shows that it is beneficial. But that is a great question, and not all insurance cover this. What we're finding is that they will cover the surgery, and then there's a robotic assist portion that they don't cover. And that's not all insurances, but some of them. Any questions? I will be around for a while if you do have questions. I appreciate your questions, your participation. Feel free to come up here, look at the instrumentation, get your hands on things, and yeah, thank you.
If you were going to tie a knot, which is very difficult with these machines, wouldn't an assistant just go in there and tie it up? Or did you not do that at all?
As far as an assistant putting it through the...
Well, it reaches in there and ties the knot on a blood vessel or whatever.
Sure. Then you have an incision that you've got to put a hand through. So the idea is we want to keep a small incision.
That's right.
I want to keep it as small as possible.
Interesting.
Nice job. I'm sorry about the feedback. Sometimes it'll kick in. See this microphone here?
Yeah.
Feeds the room. This one is for the camera.
How you doing? Hi, Kim Sampson.
Kerry.
My wife is supposed to
report tomorrow at 6:30. You're supposed to assist Dr. Heifeld, so get a good night's rest.
I will.
Are you in charge of like setting things up here?
Well, I don't set up.
So when you pick them up, you can see this is what attaches through.
Because I'm
As you rotate it, it gives you all the different degrees.
You're not sure?
Yeah, pretty sure.
Okay.
That's what they've told me anyway.
All right.
And they said when I talked to
That's exactly
Mr.
right.
Feta, do you know him? All right. He's the one who asked me from the hospital to do it. He said that I would be able to have a handheld slide advance.
Okay.
Is that possible? Because I don't want to stand
Sure, of
in
course
one
not.
spot for an
Yeah.
hour.
Yeah.
I'm kind of a moving kind of target.
And I think that is possible. You just have to request it. I'll write to summer sessions. That's who puts this on. They just asked me to do the introduction
Yeah.
because I used to work in broadcasting. But they're very good about providing you, and since it's a smart classroom, I'm sure there's
Yeah. And he had a little mic on the lapel, right?
Yeah, so this is, yeah.
He was not attached.
No.
All right.
And you for that.
Yeah, I need to.
Good.
I'm a little bit on the active
What's the
side.
subject?
Antibiotics
Oh.
and resistance and where do we go from there?
Driver, this
So
is what you use.
it's not going to be as
Is your suturing?
unfortunately.
Yeah, no, that's
It's going to
fine.
be a hard.
But it's a serious question.
And then this has electric cautery, bipolar cautery
Yeah,
to
yeah.
burn vessels.
So bring in some bacteria and viruses.
I was
that
thinking,
you
and
could
we can
release.
just like and this is like
This is where it attaches onto the surgeon,
right.
onto the patient.
Yeah. Symptoms, 12
And then
hours, you should
And
This
anybody
cassette.
travel to West Africa?
If you look here
You will have
and watch
them
the
on
tip,
eating out of your hand.
it rotates
Or they'll be
this,
all
and
out
each
that
of
door.
They're up, yeah.
controls a different degree.
Yeah, all right.
But
Motion.
sure. So I'm going to, her name is Charu Updahl, and she's the one who works with summer sessions to arrange the room and get everything
All right.
technologically set up.
All right.
So what I'll do is I'll
Yes.
email her.
You can ask me. I can tell you who.
I'm sure she must have your email,
So that's an
or at
interesting
least
question.
the fellow at the
Davinci
hospital.
Yeah.
has a website
And we'll
that has a surgeon search.
All right.
because I think that's really.
We just went and looked. It's not updated for Fairbanks.
Smart classroom,
Right.
right?
And you should be able to walk back and forth if somebody
I think
wants
so.
to.
That are doing
Yeah.
this are
And
Danny
I don't know
Robinette,
how many slides you
Mark
can put over
Corwell,
a slide. I tend to go through slides like this, and
Tom
it's-
Coe,
it kind of like is a
Bill
progression.
Montano,
So I could have 5 slides
Tim
in
Tesla.
10 seconds, for instance. But
Those
it's
are the
just
general
the arrows
surgeons.
that are
The
changing to
gynecologist
really
are
direct
myself,
somebody where I want. And to me
Jessica
to stand there the
Highfield,
whole time. But if I
Kim
can
Mudge,
stand and do
Yeah, totally.
Doris Heilman,
And the other thing you should know, you should kind of practice. Now, he wrapped up. Traditionally, when we first started the series a couple of years ago, they would go for 45 minutes and then answer for about 10, 15 minutes of questions. Nowadays, most people go to an hour. So I caution them, if that does take place, just give a short pause, let people leave if they need to. And then take it. The video
That's probably
that
not for that.
capture this with will be on air a week later, and I think it's only 90 minutes. So,
so you have to be, so from 7 we need to be completely done by 8:30 or something like that. I don't think it's gonna be
I mean, it's a fascinating. I read The Coming Play by Laurie Garrett, and what was The Hot Zone?
Yeah.
So,
There's a new it's a new show on TNT called The Last Ship, and it's about I don't think they really get into the details of what happened at the beginning, but there is a virus that has wiped out most of the Earth, and there's a few ships that had been at sea, and those are the people who are surviving.
Oh no!
And select people in isolated areas on land, and they're trying to come up with a vaccine on a ship.
Just show a clip from that for your video there. Yeah, I endorse this. But man, it's a growing topic. You should excuse the expression.
Yes, well, it's getting a little bit scarier each day.
Yeah.
I'm going to try to end it on a positive note as well, so
Thank
that
you.
people don't walk
That's
out
right,
totally depressed.
Yeah.
Oh my gosh, I'm not coming
hit
to.
by a bus, please.
Why even come to any more
Yeah.
educational seminars? All hope is lost.
That's right. We'll have those masks like the tourists that I sometimes see, as
Yeah.
if that would help.
I know that is the weirdest ancient mask.
Yeah, I know.
Ancients keep walking around with these old masks.
Yeah.
And I asked
I stabbed it in my finger.
my ex-girlfriend, actually, my ex-girlfriend and I were both over in Asia like 2 months ago, and I'm like, Colleen, are they being very respectful so that if they cough, they're coughing into like a mask? She goes, oh no, Asian people are not that nice. And she's Asian.
Yeah.
Asian people only care about protecting themselves. So that mask is for them to be protected. I said, do they realize that it's offering no protection? She goes, no. And she's a infectious disease epidemiologist.
Oh, okay.
With an MD and a PhD.
Yeah.
And she's like, no, that would be way. It's almost a fashion
Who
statement.
wants to know that? Yeah, you know?
Yeah.
I mean, oh my gosh.
It's so interesting. So,
Yeah.
All right.
All right. Well, I'll try to find one to wear for you in your introduction.
I was told to come about like a good 15 minutes early, or
Yeah.
maybe even more. Half
Yeah.
hour early.
Well, and you can load up your.
I can load it myself right there.
Right.
And then just pick the file.
Right,
And then start.
open it up and start. And the gal who was out, and I don't know if you noticed her, her name's Jan. She's with Summer Sessions too. She's the one who sets up the technology here for it. So if you show up, 15 minutes, but give yourself a half hour.
I'll do a half hour probably.
She'll kind of walk you through and get everything set up, and then it should be no problem. And I'll do that tonight when I get
All right.
I'll let her know
That sounds great.
Good.
That sounds great.
Well, I'm looking forward to it.
All right, I'm looking forward to it.
This
What's
is the
your name?
last one, Robert.
Robert, I'm John.
Hey, John. Sorry. So
Just in the Civil
this
War.
is the last one of the
No, it's the next to last one. I think Dr. Bruner and Dr. Kerry Keller are going to be talking about like brain injuries, sports injuries, head concussions.
Those are so small now. I was
Yeah.
going to say, they better have something up, like a miracle.
Hard time featuring
he
him.
after you, because everybody will be
Because people just, if nobody comes the following week, it's because they don't want to be in a crowd where they could potentially pick up a germ.
Well, I think what I'll do is get a little
Really cool.
crime
The
scene
Case Medical Museum.
and arrive around with a decontamination scene.
I could get like one of the surgical masks that have plastic and speak through that.
That's good. I think we're going to make this a winner. You're going to put this guy to shame.
He's
Yeah.
going to be. I will be kind of all over the place.
Well, good.
I gave a talk to. I don't know if I can incorporate this, but I gave a talk to I'm a pediatrician.
Okay.
And with some training in epidemiology and tropical diseases. So
Oh, wow.
that's kind of my background. I don't know why I
Lots
came
of
to
scalpels
Alaska,
that I carry
but here I
around.
am. But the.
Staking anybody?
What was I going to say? Oh, when I gave this talk to the family practitioners, the Alaska Academy of
So,
Family
did this have removable changeable heads? Is that what this knob is?
I
for?
asked questions in the middle of the talk
Oh, you
because
can't-
they're
oh, okay.
medical people.
Oh,
Whoever got
I
the
get it.
question
So they
right,
didn't
I
use different tools.
had prizes. So I'm running like I was running all over the audience.
You're going to get your own television show by the time you're done.
But I don't know if to see if there's anything that I can incorporate into questions that I
The
can give
reason
out.
you're in Alaska is, am I not correct in one of the main fruitful lines for resurrecting the 1918 flu was from cadavers dug up in Alaska?
Yeah.
They're like, there you go.
And we've got
Good on you. Let's see
some,
if we can wipe out millions.
Bring it back.
Yeah, that's right.
Oh,
an oldie but goodie.
They found smallpox. Did you read this in the newspaper? Smallpox virus cylinders in a lab somewhere in Maryland
Because she's a history person?
that they did not know existed.
Yeah, it's more my
Like,
stuff.
Wasn't it supposed to be eradicated or controlled?
Yeah, except there were two sources in the world that had smallpox. One was the CDC in Atlanta, and one was a lab in Russia.
Awesome.
And since then, like a few vials have kind of, like, maybe we sent one to Kazakhstan before we had the breakup. And we haven't been able to get it
Scariest
back
thing.
from them, kind of thing.
So which
So
hospital
they,
was it in
under
Boston you said
major
was
lock and
that
guard,
site?
transported this vial to the CDC. So
Yeah.
apparently
Good place
now,
for
apparently, there's one source left in the U.S., which is all at the CDC,
Now that's
which is, of course, like down the block from where I used
In
to
5
live.
years, maybe I'll have them.
So that in itself was a little scary.
Yeah. So you're at ground zero of the vector of
Yeah.
all vectors.
Yeah. But you're probably also close to the few remaining vaccine doses.
Oh, well, that's true.
So you always have to look on the bright side.
I can see how you're ending this thing on a positive note.
The other thing is, you think, wow, we're like in good shape because we're like as far away as Alaska. It took about 3 months to go from Boston
So they just released the new iteration inside, and they're
by boat
so
in
these will be
1918.
Oh, right.
And it took that same amount of time for the flu, the novel flu, the pandemic flu, to travel from Boston to Nome. And it wiped out high percentages of native villages. So we're talking about 3 months. And that's in 1918. You know how long it takes today?
I with the doctor who did a study on that. And these health workers would come in, and the few remaining people, would just look at them and say, "Why must we die?"
Right. Oh, yeah. It must have been absolutely tragic.
Yeah.
It must have been. All right. I'll see you next week.
See you. Nice meeting you. See you then.
How much longer will these
Series?
Tuesday sessions go on? They go on through August, or they?
No, 2 more. Well, into August, yeah. 2 more. This gentleman's discussion, next week he'll be talking about infectious diseases. And then Dr. Keller, I think, is doing a discussion on sports medicine and brain injury. Yeah.
Yeah, okay, because I know in the past they've usually had something like 7 or whatever it was, and we've been.
You've been into almost every one of them.
Yeah. She,
except for the
we
fall.
came and she fell. And so
Yeah.
I didn't go
So
that
when
way.
you do it
Are
separately,
you feeling better?
you don't get.
Oh, good.
There's not one.
Yeah, I heard. I didn't see it,
But
but
as
I
it's put on
heard.
the cassette with the motion,
Yeah, the curve.
then you'll
Yeah.
have to through it.
Oy, that's awful.
Exactly.
Well, good. We'll see you next week. Thank you. Can I shut this down?
Yeah, I took all my stuff out. The instrumentation cart. No. So this has there's an OR that's dedicated to it. It's not something that you fly to people. It's something that you fly people to it. Possibly, and the question of what if we did it like telemedicine? I mean, that's an interesting thought, and they could do that. There's no reason they couldn't, but it's that personal aspect that they want to do. Yeah, this is a great set. Pretty spectacular.
Well, thank you very much.
You're welcome. Thank you for coming tonight.
All these little X's on them.
Yeah. What do you think? You want some robotic surgery?
Yeah.
All right. Coming tomorrow?
Oh, thank you.
You're welcome.
I stabbed my finger with that needle, so it's bleeding.
Did you really?
Yeah.
Oh, ding dong.
She's telling stories on you.
Uh-oh.
She's telling stories on you.
You better go defend yourself.
That's great. That's good. I'm ready to sign up. Too bad I don't need one.
Too bad you don't need one.
That's right. Don't need any of that. No robotics for me. No, that was good. That was excellent. And you got people asking.
Yeah. It's hard because I can talk forever about data and all that kind of stuff.
And they want to hear real life stories. Sounds like you.
Right. Which, that's not what I'm used to talking about.
Yeah, but
I'm used to talking to a different.
yeah, that's great. But isn't it interesting when we find this here, the average age is 7 years. And we
Something
find
like
that
this?
in any lecture, food and nutrition lectures, mindful living lectures, and so on. And I think those 3 young sign.
Yeah.
Oh, that's good. Good job. I like the midlife change.
A midlife change? I'm going through a midlife crisis.
What can
This,
you share?
my outfit. No, this all just goes in this way. I hope it's not a midlife crisis. I thought it was stylish.
How did your radio? What station was it on? And what did they ask you?
You can get online and hear it.
970 AM. Yes, I believe.
You know.
Yes. What did they ask you? They ask you, where did you get your student?
How old are you?
You're way too young to get
I'm like, what? He's like, how old are you?
That's on the radio? Yeah. On air? And guess what he said? 35.
I can't remember how old I was. I'm 35. He's like, you look too young. You walked in, I thought you were 20, so this kid looks young. Let's say this on the radio. Charlie on 970 AM. He's a big. That's what I told him. Like, well, if I showed the beard, I look younger. He said, I can see that.
What else did he ask you?
Nothing, just kind of why robotic surgery and how long is it for it? How many surgeons do you have and why?
How old are you?
How old are you?
Interesting.
No,